Good evening, everyone. So welcome to the second webinar in the series of digital pathology. I'm Dr. Richa Sharma, and this webinar will be around platelets, the utility of the device around platelets. So I will be starting with a brief introduction of the device, that is AI100, which is a digital morphology analyzer, and which will be followed by a talk from Dr. Bernali, and then a talk from Dr. Sharita of our unit. Is the screen visible?
Yes,
I'll just briefly introduce the device, which is AI100, and it's a digital morphology analyzer. It has been developed by a company, SigTuple. It's a homegrown company based in Bangalore, and it works in the segment of tech. So this is a device which is trying to automate the entire manual microscopic process that happens in clinical laboratory. Right now, we have solutions for two of the bigger chunk of what happens in our clinical labs. And by the end of the year, we are aiming to cover most of the cases where we need a manual microscopic review. All of them will be digitized. So the aim is to basically digitize and automate the entire process. Along with digitization, some combinations with artificial intelligence that is going to facilitate most of the pathologists that work in these labs. And with this, we will democratize microscopy. That is, everybody across the world will be able to access an expert opinion, and therefore it will assist in remote reviews. So which are the segments that we have actually focused? So we know that lab diagnosis, all the investigations that happen in our laboratories, around 70% of the clinical decisions are affected by these investigations. And bigger chunk of these are hematology, is the hematology lab. So it is estimated around 4 billion samples per year are analyzed in hematology analyzers. And of these, around 15 to 20% are the ones which require a microscopic review. So the microscopic review can be done by either manually or by digital microscope. So manual method is something which we have been doing from ages. This is a reflex for us. However, it also has certain limitations, like it's time consuming, it is error prone, and it is subjective and inefficient in certain cases, and also inaccessible in larger part of the world population. If we see a global scenario, it's quite inaccessible in certain parts of the world. All these deficiencies can be met by the use of digital microscopy. However, one limitation that remains is that it's costly than a routine manual microscope or microscope that we have. And the other thing is, I think, a little bit inertia from the pathologist side. We do not want to shift to something which is new. Another area of the lab which requires an automation is the department of clinical pathology. So we know that most of our labs are flooded with the samples, and this particular department is overworked. So around 1 billion samples per year are processed in lab, and of which around 20 to 30% of the samples require microscopic analysis. So we do it conventionally by conventional methods of good old manual microscope. But if we adopt digital platforms for urine analysis, then the output or the efficiency of the pathologist increases several fold. So this is our device. This is AI100. This is one machine which is giving you two solutions. So we have shown it in Shrava. Shown it as Sanskrit for blood, and Shrava is Sanskrit for urine. So these two softwares help in automating the entire process of peripheral smell analysis or urine microscopy analysis. So these are solutions that we have right now on the device, but in the later part of the year, we will have a universal scanner, which is going to digitize all the smears that are scanned or used in a lab, like histopaths, cyto, bone marrows, everything will be digitized. So how do we use it? This is the hardware, AI100, and we can use our regular slides that we use for giving diagnosis in our labs, whether it's a manual staining or it's an automated staining, it's a manual smear or automated smear, doesn't matter. The device is will be robust enough to analyze these smears and give a result. So when we scan a blood smear, we use Shonit software in the same machine, and that gives us differential count, 7-part differential count, along with cell morphologies of WBCs, RBCs, and platelets. If we are using AI100 for a urine microscopy, then in that case, we have to use a microfluidic cartridge. And when we load the sample and run it through this, we have to select the program Shrava. So single device with 2 solutions. So this is how Shrava, or the urine automated microscopy, works. So we use a cartridge. This is based on microfluidic technology. We do not have to centrifuge the sample. There are 3 slots here, like shown in this picture. So 3 samples can be loaded, uncentrifuged samples, and we have to wait for 5 minutes, which is the sedimentation time. Then this slide is loaded on the device. The device then processes it through various algorithms, artificial intelligence algorithms, and gives us a 7-class review. That is, it gives a microscopic review about urine. Yeah. So this is how the report looks on the platform that is available for us to review. So everything is evidence-based. Whatever cell the device is or the model is classifying as blast will be shown to you in the picture, and it will also locate the cell where it's present in the entire smear. So imagine when we get a slide on our microscopes, we take time to locate the slide, locate the blast, locate the required cell. But this has already done that work for you. So all your work is basically just to review the entire report, agree or disagree with what they are saying, and finalize it and sign out the report. So it has reduced the time that is required in reviewing the smear. We also know that the transition to digital microscopy is a little painful one, because we have been trained forever on manual microscopy. So we have given this feature of how the smear looks like when we see it under our manual microscope. So this feature is basically given to easen out the transition between digital microscopy and manual microscopy. So it's just not that the view is similar to what you see under a microscope. This particular field gives you lots of information. Say, for example, on the right side, we have all the areas it has marked out from where it has picked up the cells and categorized them or given the report on basis of these cells. These are the areas from where it has extracted the cells. And when you click on, for example, in this particular picture, you're seeing FOV1 from the head end. And it's also telling you which WBCs it has extracted from this particular area. So whatever AI is doing, it is showing you a proof of it. It is up to us. The entire control, all the power is in our hands, whether we want to agree, disagree, change the report. So why is AI100 better? I'm not comparing it with the manual microscopy. That is still a gold standard. I'm comparing it with other products that are available in the market. So basically the thing is that our device is very smear and stain agnostic. That is, any kind of smear, any kind of Romanowski stain used can be reviewed in this device. There is a higher output. The image quality is excellent. By default, this device enables you work from anywhere. So that gives you a lot of flexibility. We know now that lab professionals just don't have the responsibility of sitting at one place and reporting. We have several things to do in the lab. So basically, if your technician is scanning the slide in the lab and you're sitting somewhere in the hospital or somewhere outside, you can access the report, access that particular case from your tab, from your mobile, from your laptop, and review it instantly. Also, this full field of view presentation, this kind of helps you to transition to digital microscopy, which is, if not better, equally good as manual microscopy. So this particular device is fully loaded. It has all the features, and not just that, we also have 2 solutions in one particular device. So that's very economical for all types of labs, whether small, medium, or large. So this is a team that has led us to this far, and this leadership team is supported by around 50 to 70 tech members. It's a multidisciplinary thing. So we have lots of data scientists, software engineers, robotic engineers, microfluidic engineers, along with medical doctors like us, pathologists, and product managers who work in tandem to bring out a product which is usable and it has some utility. So this was a brief introduction on AI100. With this, I call upon Dr. Barnali Paul.
Dr. Barnali has some connectivity issues. She said she'll try joining in another 5 minutes. Meanwhile, I think we can go ahead with the next presentation.
A little bit of introduction to Dr. Sharita. So Dr. Sharita is also a hemato-oncopathologist who was working earlier with HCG and is part of the medical team here in SigTuple. And she has done a lot of work in hematology, in hemato-oncology, and also on the AI front. And here she is to share some wise wisdoms on, hereditary macular.
Thank you, ma'am, for that introduction. I'm Dr. Sharita. I am working currently as the consultant pathologist at SigTuple Technologies. Dr. Barnali was supposed to show some case studies before my presentation. Actually, that would have been ideal, but now since she has some connectivity issues, I will proceed with my talk, and probably later Dr. Barnali can join us. So I will be talking about hereditary macrothrombocytopenias today. I would be sharing some images, like from which have been taken from AI100, which we have installed in the North Indian centers like Rampur, Tanda or Chamba. There are multiple devices where we have installed AI100, and these cases were actually incidentally these giant platelets were detected in routine blood smears, and there was thrombocytopenia as well. As we can see in this particular image, there were almost 128 giant platelets detected, and also the average platelet count per high power field was around 8. That means there was like per 10 high power fields was around 8. That means there was thrombocytopenia associated with giant platelets. This is one more case where there were 46 giant platelets detected. All the giant platelets are classified accurately by AI100. And also there was thrombocytopenia. That is the average number of platelets in 10 oil immersion fields was around 6. This was one more case where again there were 99 giant platelets detected, and there was one more case where there was 70 platelets detected. So what I am trying to put forward through these slides is that macrothrombocytopenia is not very uncommon, and it is like very prevalent in India as well as other countries. So I would be proceeding my talk with the following topics. That is the definition or the criteria for macrothrombocytopenia, the regulation of megakaryopoiesis, the classification of inherited macrothrombocytopenias, methods of detection of giant platelets, and also the diagnostic approach. So when do we call it as macrothrombocytopenia? The phenomenon of reduced platelet count, that is less than 1.5 lakhs, and associated with increase in the platelet size, that is more the MPV value more than 12 femtoliters, is termed as macrothrombocytopenia. So the criteria here, the criteria is at least 20% of the platelets present should be more than 4 micrometers, and that would be called as large platelets. More than 4 micrometers are called as large platelets, and more than 8 micrometers will be termed as giant platelets. So at least 20% of large platelets and 2 to 16% of giant platelets are adequate for the diagnosis of giant platelet syndromes. So now coming to the megakaryopoiesis. The formation of platelets and the mature from the mature megakaryocyte depends on myriad of the chemokines, the cytokines, and many transcription factors. So why I'm highlighting these transcription factors are because these are the genes that are mostly involved in the etiology of congenital macrothrombocytopenias. Thrombopoietin, as we all know, is the most important regulator of megakaryopoiesis. So as we go to the next image, we can see different genes that are involved in every step of megakaryopoiesis. So the genes which are highlighted in the bold letters are the ones that are involved in the etiology of macrothrombocytopenias. Like the major ones would be ETV6, FLE1, GATA1, RUNX1, or ABCG5, ABCG8, and actin-1. The most important one is the myosin heavy chain 9, which is again one of the most common disorders of macrothrombocytopenias. And there are again platelet surface receptors like GP1B, glycoprotein 1BA, 1BB, 9, and 23A. All these are the important genes that are involved in the etiology. So now coming to the classification of inherited macrothrombocytopenias. So these are classified based on the genes that are affected. So a few, they are divided into 4 classes. One is the disorders affecting the platelet cytoskeleton. So the disorders involving these are, or the entities which are included under this are myosin heavy chain 9 related disease. That is, the gene involved is again myosin heavy chain 9, beta tubulin related thrombocytopenias, alpha actinin related thrombocytopenias, most importantly, the Bernard-Solier syndrome or the platelet type von Willebrand disease. These are the variants of the Bernard-Solier syndrome. And the Mediterranean thrombocytopenia, which the Mediterranean thrombocytopenia is an old term. Now it is called as a variant form of Bernard-Solier syndrome, because it is involving the mutation in GP1B gene, which is almost similar to the Bernard-Solier syndrome. And then the next one is the disorders of platelet granules, which includes, the most important one is here, the gray platelet syndrome, which is due to the mutation in NBL2 gene. That again is one of the transcription factors, transcription regulators of megakaryopoiesis. Again, there are disorders which involve the genes regulating the transcription factors, that is the GATA1 related disorders or the growth factor independent B related thrombocytopenia. All these disorders will have associated dyserythropoietic features. So that is one of the features we have to remember in case of transcription, the genes involved in transcription factors. The others, or the miscellaneous causes for inherited macrothrombocytopenia would include cytosterolemia, which is again, now they have put it under a variant of Bernard-Solier, because they have been identified that GP1B again is responsible for this, or ABCG5 and ABCG8 mutations are also seen. These are associated with, clinically associated with, premature atherosclerosis and xanthomas. So due to abnormal cholesterol metabolism. So these are the important conditions which lead to the formation of macrothrombocytopenias. Now we discussed about the inherited causes. Now, what are the acquired causes of macrothrombocytopenia? The most important causes for acquired causes of this are the sepsis, myelodysplasia, and immune thrombocytopenic purpura, or the ITP. The clinical significance of this relies in identifying the macrothrombocytopenias and differentiating it from the ITP or the myelodysplasia. As we all know, the treatment for ITP, myelodysplasia, or the macrothrombocytopenias, which are asymptomatic basically and do not require any treatment, are clinically very significant. So the clinical relevance is that it is very critical to distinguish between the acquired causes of giant platelets and the inherited causes of macrothrombocytopenia. There have been instances, there have been reports where the macrothrombocytopenia, the congenital macrothrombocytopenias have been mislabeled as ITP, and the patient has been subjected to various treatments like steroids, splenectomy, and immunosuppressants without no improvement of symptoms or improvement of thrombocytopenia. And even it has been diagnosed as myelodysplasia, since large platelets are present and there are abnormal platelets seen on bone marrow as well. These have been treated as myelodysplasia as well. So it becomes very important and crucial to provide the patients and the clinicians with accurate diagnosis. So now coming to the methods of detection of giant platelets. So we all know we all use hematology analyzers in our lab, and it gives the hematology analyzers as such gives MPV values, IPF values. In certain analyzers, we also get IPF, that is the immature platelet fraction. These actually can help us in making the smears and seeing them on the peripheral smear. So basically, what are the drawbacks of these hematology analyzers? Few of the hematology analyzers like Sysmex or the Siemens Advia, they use impedance method for determining the platelet and the RBC count as well as RBC count. So what happens in impedance method is it relies on the decrease in the electrical conductivity when the cell passes through the aperture. So the increasing impedance basically is dependent, or it is directly proportional to the volume of the cell that is traversed. So this, based on this, if you think, the platelets can be easily distinguished from the larger cells, like, the larger RBCs or the WBCs, but it is very difficult to differentiate between the platelets and the small sized RBCs, that is the microcytes, and also the RBC fragments. So in that case, the platelets will be overestimated. And otherwise, if there are giant platelets, and these giant platelets will be counted as RBCs, and in that case, the platelets will be underestimated. Optical detection methods are also utilized in some of the hematology analyzers nowadays, and that is a more reliable method than impedance, because optical detection relies on the forward scatter, side scatter, and the fluorescence side light. So what happens is, side scatter, as we all know, indicates the size of the cell. Forward scatter indicates the size of the cell. Side scatter indicates the granularity or the internal complexities of the cell. And the side fluorescence light indicates, actually, it detects the DNA or the RNA content of the cell. So it can reliably detect different, reliably classify different types of cells. So a few hematology analyzers also include two methods, so that, like, they can alternate between each method, whatever is reliable. And that is how we can safely say that optical detection is more reliable than the impedance-based method of detection of platelets. Though flow cytometry is the gold standard for identification, and as ICSH also says that flow cytometry, flow cytometric identification of CD41 and 61 is the gold standard for, or the standard reference method for identification of platelets, manual microscopy still remains the gold standard for identifying these giant platelets. Again, the immature platelet fraction, as I told, these will be available in some of the hematology analyzers nowadays. And the immature platelets are nothing but the recently produced platelets from the megakaryocytes into the peripheral blood. So since they are, they reflect the rate of thrombopoiesis, they represent thrombopoietic activity. And these, there are few articles where they have said this immature platelet fractions can actually, if they are high, they can be diagnostic of hereditary thrombocytopenia than the other causes of thrombocytopenia. I will just deal with few of the important disorders of giant platelets, like, the major one that is involved in the etiology, which is included in the etiology of giant platelets, are the myosin heavy chain 9 related disorders. This includes a lot of syndromes, but the 4 important main syndromes that is involved are the May-Heglin anomaly, Fechner syndrome, Epstein platelet syndrome, and the Sebastian platelet syndrome. So a little bit of history about May-Heglin anomaly. Actually, Dr. May, actually, he described macrothrombocytopenia in 1909 in a family where they had asymptomatic macrothrombocytopenia. That is when he told that, it can be congenital macrothrombocytopenia. But later on, Heglin in 1945 described neutrophil inclusion bodies within the same families who had earlier detected with macrothrombocytopenia. So May-Heglin anomaly came into existence, that which had both macrothrombocytopenia as well as cytoplasmic inclusion bodies in the neutrophils. As we can see in this picture, there are macroplatelets as well as cytoplasmic inclusion bodies in the neutrophils. So later on, it was 3 more syndromes were added to this. That is the Fechner syndrome, which had features of macrothrombocytopenia and inclusion bodies. Along with it, they also had features of Alport's syndrome, that is hearing loss, nephritis, and cataract. Epstein platelet syndrome has features of Alport and macrothrombocytopenia, but they don't have the inclusion bodies. The Sebastian platelet syndrome, again, they have macrothrombocytopenia and inclusion bodies without the features of Alport syndrome. So the confirmatory test for this would be immunofluorescence for non-muscle myosin heavy chain 2A protein, and also the gene sequencing. Next, coming to gray platelet syndrome, it's a rare autosomal recessive disorder which is characterized by moderate macrothrombocytopenia, and we can see marked decrease or absence of platelet alpha granules, that is platelet granules, which gives the platelets a grayish appearance or pale appearance on blood smear, which is stained with Romanowski stains. There can be mild to moderate bleeding. The most important thing is these patients during the course of the disease can develop splenomegaly and bone marrow fibrosis. So this is a picture where you can see there are very pale stained platelets. This is the control, and this again, there are giant platelets, very pale stain. So this is one of the features. Peripheral smear based on peripheral smear, we can identify gray platelet, and not identify, at least we can suspect gray platelet, and then order further tests for confirming the gray platelet syndrome. So the confirmatory test for gray platelet syndrome is the platelet aggregation test with in response to collagen and thrombin is reduced, whereas platelet response to ADP and AA is normal. That means the secondary wave is absent, and the primary wave is present, because it is related to storage, the granule storage and release phenomenon. The platelet aggregation to restocytin is normal, but not absent, as in the case of Bernard-Solier syndrome, where it is the platelet agglutination to restocytin is absent. So now the next common disease which is associated with macrothrombocytopenia is the Bernard-Solier disease. This is again an autosomal recessive disorder which is characterized by giant platelets, thrombocytopenia, and prolonged bleeding time. There are qualitative and qualitative abnormalities involving the glycoprotein surface receptors, that is 1B, 9, and 5. So this 1B, 9, what it does is it is the receptor for von Willebrand factor, and it causes addition of platelets to the subendothelial wall and the collagen. So this is the process of platelet addition. So if GP1B9 is absent, then the platelet addition is abnormal and there will be prolonged bleeding time. So there are variants of Bernard-Solier, as I was explaining earlier. In Italy and the Greeks, Italians and Greeks, there is a Bolzano variant where again GP1BA mutation is seen, and that actually Bernard-Solier is autosomal dominant, but this is inherited as in autosomal dominant fashion, and it was previously known as Mediterranean thrombocytopenia. So these patients are usually asymptomatic, but also have features of hemolytic anemia and stomatocytosis. Another variant of Bernard-Solier syndrome is again patients with Digeorge syndrome who have heterozygous chromosome 22q11.2 microdeletion. When this microdeletion occurs, it also affects the GP1B gene, which is related to macrothrombocytopenia. So these patients, these patients with velocardiofacial syndrome, which is the milder form of Digeorge syndrome, are characterized by mild thrombocytopenia, giant platelets, no bleeding symptoms, and the VCFS features includes velopharyngeal insufficiency, chronotruncal heart disease, and learning disabilities. The confirmatory test for Bernard-Solier, of course, is the absent restocytin-induced platelet agglutination. RIPA is absent, which is not corrected by the addition of normal plasma. So this helps in differentiating it from von Willebrand's disease. So clot retraction and platelet aggregation is normal, because in Bernard-Solier, it is the addition which is abnormal and there is no problem with aggregation. Flow cytometric determination of GP1B9 expression is the gold standard of the reference method. So now coming to the diagnostic approach of these congenital macrothrombocytopenias. First, as always, we should always start with taking detailed history, any bleeding history in the past, family history, any family members are affected, past history of immune thrombocytopenia or any drug intake history, nutritional history, and detailed clinical examination of the patient. So after this, the most important test to be ordered is the CBC and the peripheral smear. On the basis of peripheral smear, we can make a certain diagnosis, or we can suspect a few disorders, and then we can go ahead, like we can order confirmatory tests based on the peripheral smear findings. Like, for example, in this table, we can see there are pale platelets. If you're seeing pale platelets, as I already described, gray platelet syndrome would be one of the DDs, and we can continue with the further test for gray platelet syndrome. Vacuolated platelets are usually seen in GATA1 related disease, and these GATA1 related disease also will have features of anisocytosis, or the erythrocytes will be affected in these cases. And if there is stomatocytosis seen in the RBCs, then we can suspect Mediterranean macrothrombocytopenia. If the giant platelets are associated with Dole-like bodies, inclusion bodies in the neutrophils, then myosin heavy chain 9 related disorders should be in the DDs. Yeah. So this is the flow chart which shows how to go about the workflow in the case of congenital macrothrombocytopenias. As we see here, first, on the peripheral smear, if we have to look for platelet size and color, if there are platelet aggregates, and the morphology of the red blood cells. If there are granules, along with giant platelets, if there are granulocyte inclusion bodies, then we should go for immunofluorescence with non-muscle myosin heavy chain 2A immunofluorescence. That would show us the abnormal inclusion bodies on immunofluorescence. And then if we see that abnormal localization of these bodies are there, then we can go ahead with MYH9 sequencing, or the next generation sequencing. If there are no inclusion bodies and still we can suspect, we have to look, as I said, in Epstein platelet syndrome, the granulocyte inclusion bodies are absent. If we have strong suspicion of it, we could still go ahead with the MYH9 sequencing. If there are no granulocyte inclusions and there are giant platelets on smear, then we should go for flow cytometric evaluation of GP1B9 and GP2B3A. GP2B3A also is deficient in cases of Glanzmann's thrombasthemia. Again, this also causes macroplatelets. So this can be easily detected by flow cytometry. So if GP1B9 is absent, then it goes in favor of Bernard-Solier syndrome. If it is just decreased and not completely absent, then we'll have to suspect heterozygous variant of BSS, as I mentioned, Mediterranean macrothrombocytopenia, or the Bolzano variant, or the velo-facial cardiac syndromes. These should be suspected. If GP2B3A is absent, then we should suspect Glanzmann's thrombasthemia, which is also called as GP2B3A macrothrombocytopenia. Yes, and if ristocetin-induced platelet agglutination is absent completely, then it goes in favor of Bernard-Solier. If it is increased or if it is normal, then it goes in favor of von Willebrand's disease. So this is the diagnostic approach for congenital macrothrombocytopenias. As I mentioned, there are different genes involved in each of these disorders. The same thing, myosin heavy chain 9 related disorders, the gene involved is MYH9, and gray platelet syndrome, it is NBL2. And for cytosterolemia, it is ABCG5 or ABCG8. And there are a few articles which says that, macrothrombocytopenia is not very uncommon in India. First, I think Dr. Bernali would be talking about the Harris platelet syndrome, which was discovered in India first in a series of blood donors in West Bengal. So Dr. Bernali would be talking and throwing some light on that. So here it's earlier it was considered it is a very mild disorder, and it does not cause any bleeding, but it is not very innocuous, and it can cause mild to severe bleeding even in Bengal macrothrombocytopenias. Harris syndrome, geographically it is located in the northeastern population, that is mostly the Bengal area, the northeastern India, Nepal, Bhutan, and also Bangladesh. These are the areas where it is majorly noticed. But Harris platelet syndrome was also discovered in one of the Turkish families, and it was also reported recently. So Harris platelet syndrome is not only seen in Indian people of Indian descent; it can be seen in non-Indian, in other race as well. So this congenital macrothrombocytopenia is not only seen in northeastern India, it is also seen in northern part of India. So as I shared the pictures in the earlier in the beginning, those are all from North Indian population actually. So that shows that it is not very uncommon, and the clinician should be aware of this condition to be treating the patients adequately. Again, inherited. Even in Indian patients where there was macrothrombocytopenia, they identified the genes. Most of the genes identified in Indian patients in India were again the same genes that were involved in the etiology, like MYH9 or GP1BB, GP1BA, GP19, and ABCG5. All these mutations are variably present even in Indian macrothrombocytopenias. So the take-home message from this talk would be the congenital macrothrombocytopenia is an under-recognized condition, with many cases being falsely labeled as ITP. So it is very important to be aware of this condition and convey this to the clinician that to avoid unnecessary and inappropriate treatment to the patients. So the basic hematology parameters like platelet count, mean platelet volume, and immature platelet fraction can help us in suspecting these disorders. Based on the peripheral smear findings and clinical manifestations, patients can be subjected to confirmatory tests like flow cytometry and next generation sequencing. So with this, I end my talk. Thank you.
Thank you, Dr. Sharita, for such a comprehensive talk. I'm sure it was very informative for most of us. Now I would like to call Dr. Barnali. Dr. Barnali, are you there?
Yeah, I'm there. Am I audible?
Yeah. Okay. Good to see you.
Sorry for the delayed joining due to internet issues.
Yeah, so I'll just introduce briefly Dr. Barnali. She is a pathologist working with Suraksha Diagnostics at Siliguri, and she has been using AI100, a digital morphology analyzer, for quite some time now. So her talk will tell us more about her experience with the device and overall experience with digital pathology. So over to you, Dr. Barnali.
Am I audible to you all?
Yes, ma'am.
Okay. So I think if I switch on the slide share mode, there is some problem with the shifting of the slides. So
No problem. Carry on.
This way? Okay.
Yeah.
So good evening to all. I am Dr. Barnali Paul, consultant pathologist at Suraksha Diagnostics, Siliguri, West Bengal. And today I'll be discussing about the interpretation of platelet count and morphology using the SigTuple AI100 device. So I will be discussing a few cases that I have scanned. I regularly scan many slides in this SigTuple AI100 device. And out of those slides, I will be presenting around 6 to 7 cases. But before that, I'll just go through a brief introduction on the platelet disorders. So starting with thrombocytopenia. So as we all know that it can be categorized into 3 causes. First is the increased peripheral consumption, which is seen in cases like drug-induced immune thrombocytopenia, heparin-induced thrombocytopenia, immune causes, infections, mechanical destruction, PNH, preeclampsia or the HELP syndrome, DIC, thrombotic microangiopathic purpura, and vaccine-induced immune thrombotic thrombocytopenias. Then next is in cases of decreased platelet production or function, like we see in cases of bone marrow failure or suppression or infiltrations. Then congenital platelet disorders in cases of drug-induced non-immune thrombocytopenia, liver diseases, infections, MDS, nutritional deficiencies, mainly megaloblastic anemia, in cases of alcoholic patients and sepsis. And also in sequestration or other conditions like dilutional thrombocytopenia, gestational thrombocytopenias, again, liver disorders, alcohol use disorder, hypersplenism, and pseudothrombocytopenia. So moving on to etiologies of thrombocytosis. So mainly it is divided into primary thrombocytosis or autonomous thrombocytosis and secondary thrombocytosis or reactive thrombocytosis. So mainly the conditions in which we see thrombocytosis is basically due to the secondary or the reactive causes, like in cases of acute infection, solid organ malignancies, anemia, mainly the iron deficiency anemias in cases of hemolysis and hemorrhage. In chronic inflammatory conditions like autoimmune conditions, tuberculosis, sarcoidosis, and post-splenectomy cases. Primary thrombocytosis we see in cases of essential thrombocythemia, polycythemia vera, MDS, myelofibrosis, and CML. In conditions like MDS and myelofibrosis, commonly we see thrombocytopenia, but still in some cases we do get thrombocytosis. Now I will be discussing a bit about Harris platelet syndrome. So this is a syndrome which is commonly seen, as already told by Dr. Sarita, in the northeastern part of the Indian subcontinent and also in the neighboring countries like Bangladesh, Bhutan, and Nepal. So what was seen in the population from this part of the country was that there were thrombocytopenia along with giant platelets. The thrombocytopenia was mild to severe. Giant platelets were seen, and but the platelet aggregation studies were normal, and the patients did not have any such bleeding symptoms or very minimal bleeding symptoms. So the leukocyte and RBC abnormalities were not detected. It was mainly the platelet count which was low along with giant platelets. And it is an inherited giant platelet disorder, and the mode of inheritance is autosomal dominant. So the reason we should know about this platelet syndrome is that it is prevalent only in certain parts of the country. So patients belonging to this origin will show this condition.
Probably due to connectivity issue, again, she might have disconnected. I'm sure she will get back. Does anybody have any questions? Let's have some interaction until she gets back on the call. In the meantime, let me just share a case here. Just give me a moment, please, until Dr. Bernali comes online. Let me see if I can share something out over here. Just give me a moment, please. So this was one of the cases. Is my screen visible, Sharita?
Yes, ma'am.
Yeah. So this was, let me show you how platelet count is actually done on our AI100 out over here. This was one of the cases, as you can see here. We take the 100 oil immersions, we take an average of that. And for example, in field number 1, field number 2, and so on forth, it gives you the number of platelet counts out over here. And this is the average which is taken from all the 110 oil, 100x 10 oil immersion fields. You will get this kind of a number out over here, which gives you the average of the numbers here. Now, this multiplied by your conversion factor, that could be a 10,000 or 15,000 or a 20,000, and that would give you the platelet count. Now, this definitely looks like a thrombocytopenia if you multiply by 10,000 or by 15,000. But the AI, which is very attuned to detect platelet clumps, definitely does flag it out here. So it's very easy for the pathologist to understand that this could be a spurious thrombocytopenia, and they quickly, you can go on to the morphology out here just to recheck that. In this particular case, as you can see, there are about 26 giant platelets detected, and there were about 78 patches of platelet clumps as well. It gives you along with the visual evidences. So these are the visual evidences, as you can see, which is simple scroll mechanism. You can see how sensitive the AI is there to pick up the platelet clumps and showcase it to the pathologist. So then you know that it is a case of spurious thrombocytopenia. And here are the giant platelets as well. The macro and giant platelets are all in one bucket. And I think you would agree with me that these are the giant platelets out over here. This is just to show you a case where, in cases where you have a lot of giant platelets, for example, in the Northeast and in conditions like Harris syndrome and all of that, the AI just makes it work very easy, and it can be used as a tool, to look at spurious thrombocytopenias, giant platelets, and platelet clumps as well. Has she joined back? Can anybody just let me know?
She said she'll join in 2 minutes.
In 2 minutes, okay. So just wanted to show you the microscopic view as well. As Richa told in the earlier discussion, the best part about our Mandara tool is that you have the microscopic view, which gives you the seamless, a transition to digital from manual microscopy. And you can use that, by looking at this. There's a rollover zoom, which is enabled out over here. As you move the cursor, you can see in the far bottom right, whatever I am pointing out over here is, it's magnified and you can visualize it over there. You can even go to the 100x directly from here. And, you could just move the field very seamlessly. You will be able to navigate. And if you have a good monitor, even at home with remote access, you will be able to view the images very easily and come up with your diagnosis. There you go. You can even go from field to field. It looks, it scans the entire discernible area of the peripheral blood smear. So all the way from the feathered edge, if you can see out over here, you have the feathered edge out over here. And as we know, our platelet clumps and all tend to sit in the feathered edge. So it picks all of that and characterizes it accordingly. And as we go up, you can go on to the thicker area of the smear, where the mono layer is and where the morphology is more discernible. So this is the representative area, as you can see out over here. And again, you can use the rollover zoom as and when you see the cells. All the way to the thick area of the smear. So this is just a representation of what your smear would be like. And to tell you very honestly, I'm right now using a hotspot connection. So even with a hotspot, even if you're traveling or you're not, you're traveling in a car, or you're not at office, or you're not at home, wherever you are in the world, in fact, and that's the whole idea about transitioning into digital, that you have access to this microscopic view, which gives you the confidence to actually create an impression and give that report. I think Dr. Bernali is back. Welcome back, Dr. Bernali. I'll be stopping the sharing of my screen so that you can go ahead. Please carry on, ma'am.
So should I continue from Harris platelet syndrome?
You can go to the case studies
Yes.
directly, Bernali. You can just go to the case studies.
After giving a brief introduction, I can start with the cases.
Sure. Please go ahead.
So as I was discussing about the Harris platelet syndrome, the only reason the concern why we should be aware of this particular syndrome is because this is a syndrome which is not having very great manifestation. Many of the cases do not show any bleeding symptoms at all. So often patients are treated inappropriately with steroids and splenectomy, and in order to avoid unnecessary investigation and treatment, we should know that whenever we come across a case where there is a case of thrombocytopenia with giant platelets, we can just clinical history regarding the origin of the patient, and then we can come to a inference that the patient may be a case of Harris platelet syndrome. So I'll just quickly move on to the cases. Okay. So this was the first case in which the platelet count, the average count given in 10 field of vision was 1.4. That is, the platelet count was somewhere around 15 to 20,000. So what this device does is it scans the fields in 100x magnification, and it gives us the number of platelets that it has counted in per field of vision. And we can also see the corresponding image. Like in this case, I've highlighted the first field of vision, where it is showing that there is one normal platelet and one macro platelet. And in this corresponding image, we can also see that the platelet has been highlighted by this square, where it is showing one normal platelet and one macro platelet. So, in the morphology part, we can also see that it has correctly interpreted 2 giant platelets as shown in the images. And in this case, there were no platelet clumps. Moving on to the second case. This was another case of thrombocytopenia, wherein the platelet count was around 75,000. and they were on an average around 4 to 5 platelets in per field of vision. If we just click on this particular field of vision, the corresponding image will be displayed. So the pathologist can correlate the count as well as the number of platelets in per field of vision along with the image. So this is the same case which is showing that in 120 field of visions which were scanned under the 40x magnification, it has picked up 18 giant platelets. So we can see the corresponding images that it has correctly analyzed the giant platelets, and there were no platelet clumps in this case. So the platelet count was in the report was released as 75,000. Case is visible, right?
Yeah, it is.
So the third case was a case of thrombocytosis. So when the automated cell counter gave a very high platelet count, I immediately checked on smear, and on one field, there were around 70 to 80 platelets. So I thought of scanning the same slide on this AI device. So when I scanned the slide on this device, the average count was given as 81, which was quite accurate. And if we see the field of visions, in some field it is showing as 61, and another field 7 is showing 113. So the platelet count was very high. The average was given as 81, and total platelet count was released as 12 lakhs. So this patient was a case of severe infection where the total leukocyte count was around 23,000 and with elevated CRP. So this is the same case wherein the giant platelets have been detected as 13 in 73 field of visions, and the corresponding images are seen. And few platelet clumps were also detected in this case. So moving on to case 4. After scanning the slide, I could see that there was a significant left shift in this case. So we can see that in this, if we see the WBC absolute counts, we can see that the device has reported as percentage-wise neutrophils 32, lymphocytes 33, monocyte 1%, eosinophils 3, basophils 2, and also it has beautifully captured the immature granulocytes around 23%, out of which there were myelocytes, metamyelocytes, and promyelocytes. It had also reported few atypical or blast cells, but there were no blast cells in this particular case. Maybe the lymphocytes or few of the distorted cells were picked up as blast cells. So the good part of this particular device is that the corresponding images are also shown along with the count. So any pathologist can just see the images and give the accurate report as to what all cells are seen, and if any blast cells are also present, or if any other cell has been interpreted as blast, that can be corrected by the pathologist. And also this case showed 7 NRBCs per 100 WBC. So this was a typical leukoerythroblastic picture, and on taking history, the patient was a known case of myelofibrosis, and the platelet count was also low. In this case, the platelet count was around 15,000. So it was the average field of vision is showing 1 to 2 platelets per field. And case 5 is again another case of thrombocytopenia with platelet count of 15,000. Coming to case 6, which was a case of severe thrombocytopenia, where the platelet count was only 4,500. And case 7, again a case of thrombocytopenia with platelet count of 75,000. And it was also showing a flag of that platelet clumps are detected. So platelet count might be underestimated. And this case was also showing us giant platelets along with platelet clumps. The images are clearly showing us that there were many platelet clumps in this slide. So definitely the platelet count was reported a bit higher than what the analyzer showed. So after using this device, since I've been using it for the past few months, I really feel that since it is a digital morphology analyzer, so any pathologist who is sitting at a higher center can definitely check slides sitting at a different center, the slides at the peripheral centers where specialists or pathologists are not available. So from there, the slides can be scanned in this device, and a doctor sitting at a higher center can definitely see the count that the device gives as well as the corresponding images And we can correlate and then release accurate reports, as well as centers where the patient load is very high. This device can definitely help pathologists in quickly screening the slides and giving accurate reports. So that's all from my side. Thank you, and really very sorry for the interruption due to some internet issues. So thank you so much.
No problem, Dr. Bernali. It was really amazing hearing you. And Dr. Bernali is one of the very young pathologists out there in Siliguri, Suraksha, who is actually using this device in routine practice. And I think she's explained the utility so well and how beautifully she showed the cases. I think it was excellent. I love the cases that you showed, and I'm sure the forum also found it very educative and intuitive. Thanks so much, Dr. Bernali, for taking your time out, and lovely presentation. And we hope to hear more from you in the future again. So this is Dr. Renu from SigTuple, the Chief Medical Evangelist for the company. I would like to conclude by saying that, yes, digital pathology solutions are very pertinent and relevant in today's practice today. It helps us to actually eliminate the bias and the ambiguity of the human mind. It gives you that little bit of the image evidence, image-based evidence, which gives a confidence for a pathologist to use remote access reporting from anywhere in the world today. Even if you're not present in the lab, it obviates the physical need of using a microscope in your practice and moving on to a digital form of reporting. All of these cases can be archived onto the cloud, which has got infinite storage, and this can be further used for clinical research. It can be used for teaching purposes or any other thing wherever it is found relevant. It brings down the turnaround time and increases the productivity and the efficiency of the pathologist. And more than anything, it also prevents the logistic challenges of actually, transporting the samples from one place to another. For example, now Dr. Bernali sitting in Siliguri, I'm sure, she'll be able to have an outreach, which a device such as this, if she places it in different other parts of West Bengal, she as a pathologist sitting right there in Siliguri will be able to give reports and, give that kind of an outreach to patients to whom, this kind of a thing would not be having an access, where pathologists are not available today. So these are all of, in a nutshell, the kind of advantages that digital pathology can offer us. I would like these things to be considered as a take-home message, whatever the points that I have related, spoken about right now. And I encourage a lot of people out over there to actually come forward to use digital practice in their solutions in their practice today in pathology, and you will definitely find them very useful in your regular practice. With this, I would like to conclude, and maybe Richa, you could just speak a few things, and then maybe or Sharita, you can just see if there are any kinds of questions from the audience, and we can just conclude this particular session.
So yeah, there was one question in the chat box saying, how do you calculate the platelet count when there are platelet clumps? How does the AI100 give the platelet count in the presence of platelet clumps? So what we do is we give the average of 10 oil immersion fields, the average platelet count, and multiplied average count. But then we also give a message saying the platelet clumps detected and platelet clumps detected. So the pathologist, with the evidence of with the help of visual evidence, he can change the platelet count and release the report with whatever the count is, like how much about the platelet counts. Depending on that, he can release the report.
There's another question on the chat box where Dr. Guharao is asking, just from commercial aspect, how much is the approximate cost per test, like in comparison to normal 5 or 6 part hematology analyzer? So first thing, doctor, it is not a substitute for CBC. We are doing automation of peripheral smear, and it is not a substitute because we do not give hemoglobin, MCV, MCH, other indices. It's just automating peripheral smear. Other than that, commercial aspect, Dr. Renu, would you like to add something?
So we could take that one-on-one. Dr. Gunjan, or was it Dr. Gunjan, or who was that, Richa, who asked this particular question?
Dr. Guharao.
Guharao, okay. So if you could have your number, please, on the chat, we would like Manohar Dhaka from our team would reach out to you on the commercial aspects and explain it to you. So Dr. Guharao, if you could just share your number on the chat.
Yeah, I will share my number.
Okay. Yes, and we will have a discussion on that, not an issue. And so
other questions also, ma'am.
Yeah, so even platelet counts, if clumps are there, there are two schools of thought, to actually give a count or not. The rest of them also can share their views on this. When we worked in cancer institutions, what we say is just platelets are adequate on smear when there are clumps present. That's one school of thought, and that's what I personally follow, and that's also acceptable. And I don't know, Dr. Bernali, how you give your counts, when there are platelet clumps out of it. Do you give it as just platelets adequate on smear, or do you actually give a count?
What I do is when we see platelet clumps, it directly means that the platelet count is adequate. So I just give a normal a platelet count which is in the normal range, and I also add a note that platelet adequate platelet clumps detected, because we can never give a definite platelet count on the base if platelet clumps are present. But I always mention it that platelet clumps are present on a note below the actual platelet count.
Right.
There's another question, ma'am. How do you standardize the smears? It's by Dr. Preeti.
You want to take that, Richa?
Yeah, so standardization of smears, you mean quality check? That is what I've understood. Basically, the basic requisite for a digital morphology analyzer or for the device is that it should be having a monolayer. A monolayer means where this RBCs are properly placed, touching each other. It shouldn't be overcrowding or overlapping. So, which is a good area of scanning. So standardization is that's all. You need to have proper smears made, whether it's manual or automated, and the device itself will flag if the smear is suboptimal. So I hope I've answered it. Otherwise, please, anybody else can add on, chime in. Dr. Bernali, if you want to add something on this.
Regarding...
Let me take that. So standardization of smears, there are two things that need to be standardized. One is the smearing and one is the staining. So for a smearing, all you need to have is a reasonable amount of monolayer, like 4 to 5 monolayers. Now you can make your smears, manually, or you can use an automated smearer. But as long as there are like 4 to 5 monolayers, I think that should be good enough for a good scan to happen. And as you can see in Dr. Bernali's slides, the case studies, which she had showed, there was a very good monolayer of those, the cells of the RBCs where they're just touching each other. That's one thing. And I think this is with practice, like any kind of standardization happens in the lab. And again, for staining, a reasonable amount of good stain, a good SOP, which is followed regularly in all our labs. We are stain agnostic. You can use any of the Romanowski stains, Leishman or MGG or GIMSA or Fields, all of that work. And again, it needn't be too dark or very, very light. As long as it's visual, it's visible for the human eye, the AI shouldn't have any kind of problem, and it's flexible enough to, give the report across different kinds of stains that are used in the country.
I would like to add something on that.
Yeah, please go ahead.
Actually, what happens is if there is a smear which is too thick or which is extremely like the smearing has not been done properly, then the device actually doesn't scan at all. It gives a message that monolayer is not formed, and in that case we have to prepare a very good smear, and then the machine interprets the results very accurately. So in case our smears are not good enough, then the machine itself gives us that message. So that in itself is one form of standardization, I feel.
Right, very true.
Yeah, very true. That is going to improve the quality even of the general working in your lab.
Yes,
exactly. Even the technicians will then
so
prepare
it is better that
so
we don't do a manual smear, right? In this case, it's better if we do it on a machine based, because manual smear, it's very difficult to get a good standardization, because it depends on the technician, or a lot of things are there. Sometimes on-site manual smears are not made. We make an indirect smear when the sample comes to the laboratory.
Right. But in our practice, madam, wherever we have put our installations, I don't think we've really found too many issues with manual smearing. So even if it is just, like I said, reasonably good, not really textbook quality, a reasonable good monolayer should suffice, and most of the times, even if you get that disclaimer from the instrument, which says that flag, that short monolayer present, if you say, okay, it will still scan it, and most of the times it will still scan it, unless, of course, it's really compromised. So you will not really face issues.
Okay. Yeah. Thank you so much. Yeah.
I think we have another question there, Richa, about the time.
So there's another question by Akash. How long does it take from scanning to reviewing the slides? It takes 3 minutes to scan this slide in the device. And as soon as it's scanned, it can be uploaded on the on your tab, and you can see it immediately. So within 3 minutes.
Yeah. So
Can I
now,
have, yeah.
so you can do a 100-cell scan, you can do a 200-cell scan, or you could scan the entire discernible area, all of which will happen within 3 minutes. So if you just scan 100 cells, it will even happen within a minute. 200 cells even within 1.5 minutes. But the entire smear, especially looking at parasites or looking at the entire, platelets, and you want in depth, like pancytopenia, case of leukopenia, where you want to scan the entire discernible area, that would, like how Richa said, take within 3 minutes. And the uploading time onto the cloud would take another minute or so. That depends on your internet speed. So with my hotspot, it just takes within a minute again. So within 3.5 minutes, you have the, images ready for review. That's as fast as possible that you can get to report.
Can I ask a question?
Yes, please go ahead.
Yeah. So I have seen Dr. Bernali. She has taken the factor as 15 most of the time for
Right.
the platelet count. So is it always taken as a constant, or does it vary?
Dr.
No,
Bernali,
no.
would you like to take that question?
Yes. For every time we do the platelet count manually through a peripheral smear, we always take, like I always calculate 10 fills under the 100x oil immersion. And then whatever is my average from those 10 fills, I always multiply it with 15,000. That gives the exact platelet count. In some centers, maybe some pathologists use the multiplication factor as 20,000. But that I think gives a higher count. So 15,000 is the best multiplication factor for a platelet count on using peripheral smears.
Okay. In that case, can you add by the AI the number of RBCs in the field, like the FOV? You give a number of number of the platelets. So Dr. Renu, maybe she can answer. So so if you just can give the number of RBCs in the field, so we'll have an idea whether to multiply by 15 or maybe 20 or 10.
I wanted to extend that answer of what Dr. Bernali was talking about. 15 is kind of ideal. Most labs use 15. Some use 10,000 as well. I've seen some labs use 10,000. But ideally, it would depend on that RBC platelet ratio, as you are rightly, suggesting. So depending on that ratio, you choose whether you want to use a 15,000 as a multiplier factor, or 10 or 20,000, right? Of course, on a very busy day, in most labs, we stick to a constant like what Dr. Bernali is telling, and kind of know with intuition over a period of time that 15,000 works, pretty much, and we kind of stick to that, unless of course it's anemia and the RBC platelet ratio really shifts, and then maybe you want to change that multiplication factor.
And can the AI add the number of RBCs in that FOV, like one column if you can add?
That's a very good feedback. We will definitely give it. So in the page of the anisocytosis, where we see RBC morphology, it gives you the total number of RBCs which have been scanned to give the percentage of the microcytes, macrocytes, but that would be like, 3,000 odd. But this is a very good point, and we will definitely take this as a feedback to the backend team, the data science team, if they could, develop a little bit of an algorithm for that and give that number so that you could use that to the RBC platelet ratio as we were talking, and that would be great. See what multiplication
because I think SigTuple will be very good in this platelet aspect, because we don't get a good platelet count in the cell counter. So that way it will be very useful. And one more thing, in the FOV, I have seen there are variations. Like sometimes we get even 26 platelets, and sometimes it's much less, 10 to 12. So do you eliminate if there is a lot of difference, so very high values, do you eliminate, or you take all the FOBs, whatever, if it is very high, very low,
First of all, the area from where the platelets are captured are from the discernible area, where there's a fairly good amount of distribution. We do not go too much towards the edge or towards the thick area where there could be probably, a spuriously high count, sitting out over there. And of course, then we leave it to the average, obviously, right? Because it depends on the smear and how the spread happens on the smear. That's not very uniform, as we know. But yes, so I think we pretty much have, copied what we do on manual, but we have chosen the area of scan a little more, a more, what do you call it, a reliable area of scan, which will not give you too much of a bias. And that has been done with certain validations, on the scan algorithm. Finally,
so we can rely on that. So no problem
definitely,
with that.
You can. And I think Dr. Bernali would give you that unbiased view because she's been using it so often, regularly. She's seen there has been a very good correlation with her manual microscopy, and it has even beaten the impedance, method. What she gets from the hematology analyzer. Most of the times, in fact, she says there's an underprotection in the hematology analyzer, and she has been able to match our values with her values on manual microscopy. Isn't that right, Dr. Banali? I think you have told us this many times earlier.
Thank you so much. Thank you.
You're welcome, and thank you for that, for all the questions and feedback. It's extremely valuable.
Yeah, and that RBC, if you can add, it will be very useful.
We would do that.
Okay. Thank you so much.
Richa, any more questions?
Dr. Babu Prasad Natarajan, could you please ask your question?
Or maybe Sharita, you can just read it out. Somehow I'm just not able to see that page suddenly.
How about identification of platelet parasites, if any protozoa, if it's present, and is there any provision to identify the platelet parasites?
Platelets or parasitized platelets? How to count parasites?
Parasitized platelets. That's what he
said. Would you take that? Because as far as parasites are considered, we just look at malarial parasite at this point of time, but not parasitized platelets. So we don't do that as of now, but you can throw some light on it. If anybody on the, on the call has some experience with that, can throw some light on that.
Actually, whatever field of visions the device is analyzing and giving us the count, those particular field of vision images are corresponding images are also shown. So in case, even though the device is not giving us any analysis of the parasitized platelets, but at least we can see the images. So any pathologist can just view the images, and if they can pick up any parasite that is visible in those particular field of visions, then that is the utmost we can do from this device.
Right.
I think there are no more questions in the chat box. If anybody wants to ask any questions, they can go ahead.
If there are no more questions, Richa, Sharita, I don't think there are any more questions.
Yes.
No more questions.
No more questions.
I thank all the participants today for their valuable time, taking it out on a Saturday night, and for engaging with us. And I think we had a very good interactive session, and it has given us a lot of encouragement as well, to go ahead, especially for platelet counts on AI100. And with our esteemed guest speaker, Dr. Bernali, thank you so much for your valuable time as well, and for an excellent presentation with so much of, your practical experience and not just the theoretical part of it, with the lovely cases that you presented. I think that would have enlightened a lot of audience who have been on the call today. And we hope to engage with you in future as well, and we hope to take it forward. Thank you, Richa. Thank you, Sharita and Dhaka as well for making this happen today. And it was have a very good evening, everyone.